Thank you for staying with us on Checkpoint. An acute shortage of antiretroviral drugs has hit the country, exposing people living with HIV to an uncertain future. The shortage comes months after the World Health Organization said nearly 70 countries were at risk of running out of HIV medicines due to coronavirus pandemic that has interrupted supplies. Here's KTN's Kevin Ogutu with more on the story.
With measured steps, one of the peer educators in one of the public health facilities leads us to her house, where she keeps antiretrovirals, hers and her husband, since 2008. She takes the matter of antiretrovirals seriously.
Sasa kupitia ile hali yenye nilipitia nikipimwa mpaka saizi, ninajua vile naweza bebereza mtu na ingie kwa box yangu natumie dawa na kuwe na maisha mzuri.
In the facility she works in, about 600 clients come there for their ART treatment. Lactating mothers used to get their supplies monthly. Other people living with HIV every 3 months, while others 6 monthly depending on their viral load. But since the pandemic, things have turned from bad to worse, with the facilities forced to ration the vital medicines.
Sasa unapata mtu anatoka mbali, anatoka like Kakamega kukuja kuchukua dawa sahi, anafaa kupewa dawa miezi 3 ama 6, anapewa dawa ya wiki 2 arudi. Ni pigo kubwa sana. Wamama wenye wananyonyesha hawana dawa ya kuzuia mtoto asipate virusi kwa mama, inaitwa nevirapine. Nevirapine haiko kabisa. Ukipata hiyo mwezi, labda hiyo mwezi hautapata, na hiyo ilianza kuanzia last year.
Jua mtu akiwa na IVL kwa sababu saa zingine anaweza kosa dawa. Mwenye walitoka mbali labda alipewa dawa for 2 weeks. Akaenda akatumia hizo dawa for 2 weeks zikaisha. Hana fare ya kukujwa. Automatically this person will miss drug. Na mtu akimiss drugs lazima virusi yake itaenda juu. Na virusi ikiwa juu, automatically huyu mtu atakuwa na opportunistic diseases. Magonjwa zingine zinaweza kuingia. Na hizo magonjwa ikianza kuingia, hiyo mtu yuko kwa hatari. Hiyo ndio sababu mtu anaweza kufa juu ya hiyo ugonjwa ya ukimwi.
This shortage is not unique to Nyanza. In Mombasa, to avoid the risk of running out of the life-saving drugs, they are rationed. In Nandi County, Septrin has been missing in the hospital since last year. Kenya has about 1.5 million Kenyans living with HIV. Homa Bay, Kisumu, Siaya and Migori are the counties with high HIV prevalence. In 2009, just over 1 million adults and 72,968 children were on antiretroviral drugs. National AIDS and STI Control Program NASCOP official Dr. Catherine Ngugi says there has been a hitch in supply of HIV and AIDS drugs and testing kits due to COVID-19. A consignment of life-saving HIV and tuberculosis medicines has been lying at the port of Mombasa since January 18, following a tax tussle between the Kenyan government and the U.S. Agency for International Development, USAID. However, the Ministry of Health has allocated 1.8 billion shillings for procurement of HIV commodities to last the country for 5 to 6 months. Kevin Ogutu, KTN News, Kisumu.
So Kevin Ogutu has sort of painted the picture for you so you get to understand what people living with HIV and AIDS are going through. I want us to get another first-hand experience. And we're speaking to Doreen Mora, who's an HIV champion. If you realize in the stories that were done by Kevin Ogutu, we blurred the faces of the lady and the gentleman. Mora was very categorical that she's open about her status and she would like to have this conversation with us. So first of all, Mora, thank you for speaking to us on Checkpoint. Good evening.
Good evening to you, Linda. How are you?
Good. Listen, let me start from your tweet that actually forms the basis of this conversation. You said there is a shortage of ARVs in Kenya. People on the DTG regimen are now being given 1 month or 2 weeks dosage. Such scenarios make me hopeless because how can we fight HIV without ARVs? How are we going from 6 months dispensing of ARVs to about 2 weeks? Please share with me your experience in terms of getting HIV drugs in the last couple of weeks.
Well, from the beginning of last year when COVID-19 really hit us, there was a multi-month drug dispensing whereby patients were being given 3 to 6 months ARVs, and they will go so that they can avoid, people living with HIV already have a compromised immune system. So they don't have to frequent the hospital often, because hospitals are like hotspots for COVID-19 infections. And that actually gave most people living with HIV the hope that we can be safe and we can take our medication for a long time. 6 months is like you're going to hospital only 2 times a year.
Yeah.
And the 3 months you're going to hospital just 4 times a year. And that is, that is one thing that is things that you can work with. And, there is still stigma of HIV and AIDS still in Kenya. So a lot of people tend to take the medications far away from their locality so that people don't get to see them. So personally, I've been getting medication very well. But now the medication I have ends next month on 15. So from, I think, towards the mid of this month, that is when the shortages started being very acute, and patients started being given 2 weeks, 1 month medication. So imagine going from 6 months to 1 month.
Okay.
It means you have to keep traveling back to hospital. So if you live in Kisumu and you take your medication in Kakamega, you have to go back after 1 month. That is just 30 days. And now we have economic situations that are not very favorable for us. And it gets me worried because now we have a pandemic, we have a shortage of ARVs, and we have lockdown in some counties. And it's really worrying because now I feel like the gains we have made in the HIV response might be very threatened going forward.
Yeah, and that is the concern, the gains, clawing back of the gains that we've had so far. Tell me, Maura, what explanation have you received so far? And I'll try to get some of these answers from Health CS in a couple of minutes as well.
Well, okay, the last time when we had a tweet-a-thon with the network of people living with HIV and AIDS in Kenya and other partners, the response was the medication is coming next week. And we are really waiting because it's not even just for people living with HIV who is us. We also have mothers who are living with HIV and trying to give birth to HIV-negative children. The reason why I said I am hopeless actually is because I tell people, take your medication, you will become virally suppressed, you will live a normal life. I've lived with HIV my whole life, and I can tell you that there is a normal life after HIV positive diagnosis. But how can I encourage you like that when in the real sense there are no ARVs? Because ARVs form like 90% of the hope we have as people living with HIV. Coming from a time when there were no ARVs at all in Kenya to a time where they became expensive, and now that we have access to ARVs, then we go back again to there is a shortage. This shortages should not be here. They should not be affecting us. We should now be just dealing with the HIV and AIDS stigma. That is what we should be talking about and eliminating. But now most of the time you find us going back to there are no ARVs, there is no nevirapine for children, there is no early infant diagnosis kits. And it's like now, it's like we're mark timing. And we have a target of ending HIV and AIDS new infection by 2030. That is 9 years from now. So we can't really afford to have this.
Yeah, this is not an ideal scenario if you want to fix this by 2030. Tell me, Doreen, as we wrap this conversation up, so you said you were told they're on the way, they will be here any moment from now. If they don't get here on time, what are the alternatives for you?
If they don't get here on time, then it's a 2-week, 1 month dispensing for people who can actually be able to access the medication. Personally, I don't know until I go to hospital and then I'm told, hey, this is what we're giving you for now, manage it. Because the ARVs are coming in, just a minute, they're coming in this big bottle. So this big bottle is actually being like divided for people to get. So imagine from this to now being given ARVs in like an envelope, like in a chemist. It's honestly a very discouraging scenario. Yeah.
So initially you'd get a full bottle. Right now they're being subdivided into smaller portions, and there's economic implications in it as well, because you say, look, there are people who can't go to the nearest health centers because of stigma, so they have to travel.
Yeah.
So what then this means is that this person has to make constant travel to go and get their medication. Some of them may not be able to afford it. And this will put people in a scenario where they will give up and stop looking for this medication, and that is not a scenario we want.
Exactly.
Good. I hear you. Doreen, Mora, thank you so much for speaking to us on Checkpoint. I really, really hope I can get some of the answers to some of the questions that you have from Health CAS. Dr. Mercy Mwangangi will be speaking to her in a couple of minutes. Let us take our second break here on Checkpoint. We'll be right back.